Hi, I'm Josh Finkel, and I'm a fourth-year medical student at the University of Maryland School of Medicine in Baltimore. I'm going to talk to you today about the association between violent injuries and crime commission. There's literature that shows that having a history of violent injury is associated with being a victim and/or a perpetrator of future violent injury. There's a complex interplay of many different factors that likely play a role in this phenomenon of repeat victimization and/or perpetration. A better understanding of the patient characteristics associated with violence after discharge may help us with injury prevention efforts and disrupting the cycle of violence. Thus, we undertook our study to look at the association between violent injury and future violent crime charges. We hypothesized that patients admitted for a violent injury are more likely to be charged with a violent crime after discharge compared to patients admitted for nonviolent injuries, after controlling for socio-demographic factors. So in our study, we had a retrospective cohort using a historical dataset of 1,099 consecutive patients discharged from a Level 1 trauma center between 1994 and 1996. Each subject in the dataset had personal identifiers and was interviewed during their admission with regards to various socioeconomic factors such as demographics, income, education, substance use disorder, etc. These subjects were linked to a statewide registry of all charges related to crimes committed in the state from 1991 to 2018, so inclusive of our entire dataset and follow-up period, and they were all matched using the subject name, date of birth, and race, and all three had to be a match, thus allowing for a robust linkage. We then used a Cox proportional hazards model, adjusted for sex, education, and substance use disorder, because we wanted our primary outcome to be time to charge for a violent crime, and violent crime was defined as robbery, rape, assault, or murder, which is consistent with the FBI definition of violent crime. So this is our Table 1, and what I would like to point out is that you can see that the violent trauma population is not your average population. You can see that the violent trauma population is predominantly male, predominantly African American, predominantly young, ages 18 to 35, predominantly unmarried, low income, less than $20,000 in 1995 dollars, and has a high rate of substance use disorders. Now, here is our Kaplan-Meier curve with our results. So this curve shows the time to first violent charge after discharge from the hospital. What you can see here is that within 5 years, a quarter of the subjects with violent injuries have been charged with a violent crime compared to 7 to 8% of those subjects with nonviolent injuries. In the total 22 to 24 year follow-up period, 36% of the subjects with violent injuries had been charged with a violent crime. We found that most of the violent charges, 69.8% of them, occurred within 5 years of discharge. Then we looked specifically at the mean time to a violent charge. We found that just 16.3 months, or just over a year, was how long it took on average for a subject with a violent injury to be charged with a violent crime after discharge. Next, we looked at the Cox proportional hazards analysis to identify the patient characteristics associated with being charged with a violent crime after discharge. You can see that violent injury was a significant risk factor with a hazard ratio of 2.5, supporting our hypothesis. Aside from violent injury, other risk factors were an estimated annual income less than $20,000 in 1995 dollars, age from 18 to 35, male sex, and any substance use disorder. All of these were significant risk factors for being charged with a violent crime after discharge. Note that substance use disorder in particular has a very high hazard ratio of 41. Education and employment status were not associated with violent crime commission after discharge. So, these are the risk factors that we should be looking at when we have trauma patients, particularly violent trauma patients, in order to intervene and reduce their risk of being charged with a violent crime in the future. I want to also note that income and substance use disorder are modifiable risk factors, while the others are not. So, What we can take away from this is that of the patient characteristics associated with an increased hazard ratio, income and substance use disorder are modifiable risk factors for being charged with a violent crime after discharge. As such, if we can address substance use disorders and low income in violent trauma patients, we could potentially decrease the rate of violent crime commission after discharge. So, admission to a trauma center is a great opportunity to prevent future violence and crime. Patients with violent injuries are a very high-risk group that we should be targeting for intervention. I would like to thank you all for listening to this presentation, and I would like to also acknowledge the University of Maryland School of Medicine Office of Student Research, Dr. Zachary Dezman, Dr. Laura Buchanan, and Dr. Kinjal Sethuraman for their help with this project.